Can you hear me? So for those of you who don't know me, my name is Rebekah Marsh. I'm one of your clinical nurse educators. I've been at Harborview for about 10 years before I was in the Neuro ICU. And today we're going to talk to you about an improvement framework that we have created with the help of our Nursing Practice Council to help our nursing councils do improvement work, a little bit of a guide for them. So we've talked today about how we started our shared governance journey in 2015. But this past July, when Matt and I were working with the Nursing Practice Council, they asked a question, and I think it was really a significant moment, a turning point for us in terms of understanding the need for support. The Nursing Practice Council said they wanted to know more about what other hospitals were doing to support their shared governance councils because they were struggling with their improvement projects. They'd been very ambitious, as Tim pointed out. They wanted to save the world, and I agree, I'd like to save the world also, but they were feeling really frustrated when they started off with really ambitious goals, and then they were met with stumbling blocks, and maybe they didn't line everything up early on, and they learned that they couldn't go forward with a project just as they were about to launch. And that's incredibly frustrating. And while we want these councils to be able to make mistakes, we don't want them to feel that sort of deep frustration. So because of the question that they asked, we decided to develop an improvement framework or guide for them to do their work.
So hi, I'm Matt Liechty. I am also a clinical nurse educator. I've been a Harborview nurse since 2003. And I've had the pleasure of working with Rebekah and our Nursing Practice Council on this framework. And the framework you can see is in page 7 of your handout. That's in the draft there. But what is the purpose of developing of that framework? What role does it play? And the first role is that it creates a shared mental model and a shared language for the nurses in the UPCs and you guys as managers and the advisors to execute the projects that they're doing. The second is that it provides a procedure for the nurses, managers, and advisors, and many of our nurses are novice to project management, but it provides a clear step-by-step procedure for how to execute a project at the unit-based level. This allows them to sequence and organize the resources and the education that they need based on where they are in their project. And the final purpose of the Project Improvement Framework is to embody the 4 domains of Harborview's professional practice model that Suneva has talked about. So when we look at the first purpose here, to have a shared mental model and a shared vision, we've all got this in our Just Culture trainings. Thank you, Liz. Simon Sinek's The Golden Circle. And we are very, very good here at Harborview, like most other organizations, in saying what it is we do. We talk about our mission population. We talk about the great care that we give them based on our clinical centers of excellence. And the what that we're talking about here is empowering our direct care bedside nurses to drive change in their nursing practice from the bedside. That is our what. How are we doing that? We're doing that through the shared governance structure that we've been talking about today. And the improvement framework is a piece of that on the project level. But why? What is our why for creating an improvement framework and also just doing this in a whole shared governance journey? And we've really come up with 2 reasons for our why, for why our direct care nurses should be empowered to do project improvement work.
So it's all kind of about taking an old problem and looking at it in a new light, looking at it through a nursing lens more specifically. So everyone's perhaps familiar with the epidemic of patient harm. We know that in 1999, the IOM released a report saying that almost 100,000 Americans every year die because of us, because of medical errors. And we thought that that problem would be easily addressed, but when we looked at it more recently, we see it hasn't gotten better. In fact, it perhaps is getting worse. We are the second leading cause of death in America behind heart disease and cancer. So this is something that we've heard about for a long time. It's not news to us. when we look at the root causes of sentinel events reviewed by TJC, we see time and time again human factors tops the list. Remember that human factors is where the end users, or who in this case would be our biggest group of end users in the hospital, nurses. So how do nurses come in contact with our systems or our technology? So if we're thinking about nurses being our biggest group of end users, there's a real reason to engage them in the solutions that we create for our problems. I also want to think a little bit about the origins of shared governance. So shared governance came out of, it was nurses' response to the nursing shortage in the 1970s. It was our answer to how do we do more with less. And it's based on the principles of partnership, equity, accountability, and ownership. And in fact, today we face a lot of uncertainty around the Affordable Care Act, and we keep hearing that another nursing shortage is coming. We may even start to be feeling that right now. We don't know how big it's going to be, but we know it's coming. And I would like to propose that shared governance is still a viable solution to our problems. And as we start to feel the pressure, I would not want us to abandon this effort, because I think there's a lot of good solutions in shared governance. So one evidence of evidence-based practice is using the best available evidence and applying it in consideration of the care environment. And to further make my point, who is in the best position to assess our care environment? I would like to believe that nurses have a lot of opinions about how we enact change, what changes need to be made, and that their voice is really important in this instance. And I have even more evidence to show you why engaging direct care nurses is a good way to go. So the same year that we launched shared governance here at Harborview in 2015, the Neuro ICU participated in a grant program, the AACN Clinical Scene Investigator Academy. So this is a 16-month leadership program. It's designed to put direct care nurses through an educational curriculum, teaching them how to do improvement projects at the bedside, and at the same time, they develop projects on their units and roll them out. So across the country, 249 nurses in 66 hospitals in 9 geographic regions, including Seattle, Harborview, had teams of nurses working on problems like early mobility, HAIs, pressure injuries, delirium, among a number of other topics. And these groups of nurses demonstrated time and time again the ability of direct care nurses to improve patient outcomes and at the same time save hospitals money, because that was one of the really important tenets of the AACN CSI Academy, is that the nurses need to make a business case for their improvement. I want to show you the results of that Neuro ICU project, because it's very rare to be able to look at the data of 4 years from a project. So this is, while I was involved in this project, and I have a reason to be biased towards it, I think it's a really good example of what nurses can do when they're engaged in finding a solution to a problem, when they actually care about it. So the first year, pre-baseline data, Neuro ICU was mobilizing patients at about a 50% rate. During the year where we participated in the AACN CSI Academy, we transformed that rate from about 50% to 80%. And then we have 2 years of post data. Most of the team members aren't working in the Neuro ICU anymore, so this is just a good example of how it anchored well and stayed really sustainable. So that's 2 years post-intervention sustained data, and I think we would all like to see those kind of outcomes in our improvement work. So maybe we need to engage more with our nurses.
So we took, Rebekah's provided this great example of our Neuro ICU nurses using the CSI framework to drive and not only create change, but sustain that for 4 years, which is pretty remarkable. So when we were asked to come on board as advisors, we asked the Nursing Practice Council, which was made up of all of the chairs of the 25 different councils, and we asked them, what are the biggest challenges that you're facing in your project work? And they were very clear in saying that they did not feel like they had They were excited, they were happy to have the resources, but they didn't have fundamental knowledge and skills in basic project management. We got a lot of, we just don't know where we are, we don't know what to do next, and we want to do this, but we kind of just don't know how. So we wanted to check that perception with the advisors, and when we talked with the advisors, we found that a lot of the concern was that a lot of the practice projects were ill-defined in sort of the problem that they were trying to address, or much too broad in scope. One of the things that we heard over and over again from the advisors was they want to keep jumping to solution. I think a lot of the idea was, we know what needs to be fixed, we'll meet for a few times and start something and it'll be great. And we always know that's a great recipe for a successful project, right? It's totally how it works. So when we went to the Nurse Practice Council and presented the framework to them, and they were very excited. They had a lot of questions, but they were very excited because they said, I feel like I know where we need to go and what happens next. But we knew that it wasn't enough for them to just have it for the direct care nurses. If we wanted to build cultural change, this needed to permeate the entire shared governance structure. So the framework was taken to the Nursing Executive Board as well as the Clinical Inquiry Council and the Professional Development Council, and they provided feedback and endorsed this as our kind of project improvement map throughout our shared governance structure. And so here's version 2.0 of the improvement framework. How many of you have seen this or version 1.0 online? Just curious by showing hands. So less than half, okay. So to orient you guys to this a little bit, you can see here there's 8 steps that are involved in sort of a stepwise fashion here. I like to think of this really as a map, and this is a map that helps our UPCs lead to hopefully a sustainable practice improvement model that's driven by bedside nurses. So if you look up at the top there where it says project determination, we have that in blue, and that really encompasses the first 3 steps, the majority of which are blue. And we know that in order for them to take on a project, the project has to be in aid of something. Like Darcy said, these aren't just school projects. This should be helping improve outcomes for our patients or our nurses. So the project they're doing needs to answer a question or a problem, and that requires brainstorming and defining before they even jump to solution. So this is when the UPC is determining what their project is going to be. And that really requires them, if we consider our professional practice model as kind of the compass of our map here, that really requires our nurses to dip into the culture of inquiry domain in their professional practice. As we move to step 4 and step 5, which are red, and they're actually developing their project, that's where they've defined the problem and they're planning what is going to be our project. What problem are we trying to solve and who do we need to collaborate with? And we've made this red because we feel like this really plays into the exemplary practice of project management. Those of us who have managed projects before know it's all about planning and it's all about collaborating. As we move further along into step 6 and step 7, step 6 is where we're actually launching the project. And step 7 is where they're looking at the data and scaling and sustaining it if necessary. And we have that purple because when we look at our professional practice model, we see that in order to get a project off the ground, but then even more importantly sustain it, they really have to develop and grow and use their leadership competencies in their professional practice. And this entire process is bookended in green in steps 1 and steps 8, because whether our UPCs, our direct care nurses, are forming the team and learning how to run a meeting, learning how to take minutes even at a meeting and be effective in their communication, or they're presenting it maybe here, or maybe in another conference, or maybe even in a journal, they're really developing their professional practice. So we really see this as embodying all 4 domains of our professional practice model. But this is a living document. This is not just sort of a one and done framework. One of the things that the NPC talked about is needing more knowledge and skills. And so this provided a shared mental model, but we wanted to build a toolkit for them that would allow them to access the necessary tools depending on what step they were in the process. So if you go to the website and you click on any one of these steps here, and this is still in progress because the NPC is building this with us because we wanted them to own this, what you'll find is improvement tools. A lot of them are from IHI, a lot of them are from AAC and CSI Academy. Paula's developed a really nice resource guide that helps our UPCs identify who are maybe key stakeholders they may need to talk about here at Harborview depending on the scope of their project or the type of project. There's reference articles, we have contact information in there, and then there's a screenshot here of Rebekah doing one of the lecture capture videos. What the lecture capture videos are 10 to not more than 20-minute videos that give a little bit deeper dive into core content or knowledge and skills that they need to execute that step. And 2 of those that we hit early on because we found that a lot of our UPCs needed more knowledge and skill in this was one is with gap analysis. So this is a modification we took from Thomas Gilbert's behavior engineering model. And this is the first step really in step 2, that we're encouraging them to, as they're considering what problem do you want to try to tackle in your UPC, to really look at the 3 major environmental buckets or factors and the 3 individual factors and say, why are our chemo patients reporting so much more pain than other hospitals or whatever metric they're trying to move. So this definitely takes time, but it's helped them really begin to look to select problems before just jumping to a solution.
Another one of the tools that we featured to kind of address some of the problems that the practice councils were reporting early on is the PDSA model. This is from IHI. So in the Plan, Do, Study, Act model, you plan your intervention, you select a solution to your problem, and it's got to be something that's measurable. And then you carry out your intervention, and while you're doing that, you document your observations of the outcomes. And you use those outcomes and you study them before you decide to adopt, adapt, or abandon your solution. This is very much like the nursing process, which is part of what I like it, in assessing and then reassessing. But what we don't do as well as nurses naturally is when we're doing our project work, we really forget to document our outcomes and study that data to base that on whether or not we're going to keep the intervention or not. And the other thing that this model does so effectively for our nurses that they were struggling with is to break it into little pieces. You can't save the world in one day. So we got to break it into manageable chunks of work that we can take on. As an example, we have delirium across the bottom, and you might want to break your delirium interventions down to roll them out, because rolling out assessment and quiet time and early mobility at the same time may not be the most successful way to tackle a problem. So really breaking things down and using the data to measure outcomes. So this is kind of where I talk to you as nurse leaders about what is your role with this improvement framework. There's been a lot of talking at you today, telling you about the work that we've been doing, but what's your part? So definitely we want you to be active champions of UPC projects, because we want you to take ownership of this process. A lot of times you hear people talking about buy-in and getting buy-in. But when you ask people for buy-in, you're saying that the solution has already been developed and your input isn't as much desired as we just hope that you adopt it and carry it forward. But what we want is we want you to take ownership of this shared governance process. It's yours. The model that we're developing is very adaptable. So it's important that you feel like it's as much yours as it is mine or Matt's or the Nursing Practice Council nurses who've been developing it. We want to reinforce positive lessons about change management. Tim did a really great job talking about letting them make mistakes, but it's not the goal for them to make mistakes. We should always be giving them our best advice. And then they can take that into consideration and make their own decisions, but we shouldn't be setting traps for them. We want you to develop your facilitation skills. Nurse leaders at Harborview are generally promoted for leading from the front. Those are qualities we typically value in leaders. But what we want is for you to continue to lead from the front, but know when it's time to step back and let other people make decisions. And it's a balancing act that I am continuing to struggle with because I got here because I like the sound of my own voice. Just like Nate.
Not that much.
Not that much. And we really want you to support UPC recruitment and retention because we can't do this without seats in the chairs. And we want to grow our shared understanding of improvement work. This has been an incredible learning journey for me as I continue to learn more and more about improvement work. And I know you guys are all going to attend an upcoming QI boot camp. I think it's part of your PCS strategic retreat. And the QI boot camp is put on by UW Medicine Center for Scholarship and Patient Care, Quality and Safety. So they're going to introduce a lot of improvement tools, and not all of them are on our framework. I had a nurse manager ask me recently about using those tools, and what we're asking is when you use improvement tools that aren't already on the framework, that you put them in the correct context. So what we want to do is start developing a shared language. Maybe you mention which phase or step you would find that tool in so that everybody can put it into perspective, if that makes sense. And since I forgot to mention it before, accountability is always an inside job. And while the unit practice councils are their own bodies, you can't really help support them if you don't know what's going on with them. There's a lot of collaborative support efforts going on in addition to the framework that we've been working on and developing this class for you today. I just mentioned the QI boot camp. It's totally in alignment with all the work that we're doing. It doesn't compete at all. We're also aligning our advisors. We have grown to a number of, I think, over 24 unit practice councils right now, and our advisor numbers didn't grow as quickly. So we need more advisors to support these groups. Anyone who's interested. Also, the NPC is working on developing its own transitional workshop. So that's the Nursing Practice Council, composed of the UPC chairs. And they would like to work on a workshop that would happen as they transition leadership every summer so that they could pass off their knowledge from the offgoing leaders to the new leaders and set them up for success. And Jeannie Lowe and Amanda Potter from the Quality Improvement Department are working on an A to E UPC dashboard pilot. So 5 East and the Burn Peds ICU have both volunteered for their UPCs to be pilot units for developing a unit practice council dashboard where their project data can be tracked on the A to E platform. Our groups have really been struggling to get data. You know as nurse leaders that it's not easy to get data. It's been even harder for our fledgling UPCs. And so connecting them with the people that can get them access to data has been very important. And you learned today about how we're deepening our own understanding of our professional practice model. And that all contributes to supporting these councils. Because we really do believe that the support of these councils, their success is our success, and supporting them is supporting our house. So I'm really, really excited about the work that we've been doing this year to grow and build on what's been happening since 2015. And we are excited to hear if you have any questions about the improvement framework. You are such a quiet group today.
Where on the website is this?
We're going to cover that next. Yeah. What a lovely lead-in.
Yeah.
So we will show you on the website.
Yes.
And I will say, since there aren't questions, we put this proposal out, and it was kind of This is the top level of what we propose to develop. We're really working in these early phases to add content to the website. So we put out the whole thing to see what it looked like, and now we're adding these tools and adding videos in here, and as we record more videos, we'll build up this way, but we're working in the early stages still. Okay.
Thank you.
Thank you so much, Matt and Rebekah. Matt